Hi, this is Piyush Bhargava and you are watching the Octreotide scan teaching file. Let's review the protocol that we typically use to do the Octreotide scan. The most common indication for doing these studies is to evaluate patients who have neuroendocrine tumors, the most common neuroendocrine tumors being carcinoids. The radiopharmaceutical that we use to do this study is 6 millicuries of indium 111 pentatreotide, which is injected IV, and 4 hours after injection and 24 hours after injection, we acquire whole body images in anterior and posterior projections. When we see anything abnormal that needs further evaluation, we do a SPECT or a SPECT CT. Remember, indium 111 has a 67-hour half-life, has two photo peaks of 174 and 247 keVs, and we use a medium energy collimator to image these patients. The mechanism of uptake is receptor binding to somatostatin receptor subtypes 2 and 5. Octreotide or pentatreotide is a somatostatin analog, and it's labeled with indium 111. After it's injected, it goes and binds to somatostatin receptor types 2 and 5, which are overexpressed on the surfaces of neuroendocrine tumors. The physiologic distribution is seen as uptake in the spleen, which is more intense than the liver, and excretion of the radiopharmaceutical from the kidneys into the urinary bladder. The critical organ is spleen. Case number 1 shows whole body images in anterior and posterior projections in a patient with a negative octreotide scan. We see physiologic distribution in the spleen, which is best seen in the posterior projection. The uptake in the spleen is much more intense than the uptake in the liver, which is seen here, and there is excretion of the pharmaceutical from the kidneys into the urinary bladder. There is physiologic bowel activity. So those are the sites of physiologic uptake. There is no focal abnormal uptake to suggest presence of a somatostatin receptor expressing tumor. Here is another example of a negative octreotide scan where we see spleen more intense than the liver, excretion from kidneys into the bladder, faint physiologic activity in the pituitary, and then physiologic activity in the bowel and the urinary bladder. Case number 3 shows a great example of an artifact and the utility of doing a SPECT CT. We are looking at whole body images in anterior and posterior projections. The spleen appears enlarged, shows intense physiologic uptake. The liver shows a focal uptake at the inferior edge. There is excretion from the kidneys into the bladder, physiologic bowel and urinary bladder activity. If you were just evaluating the whole body images, you may feel like there is metastatic somatostatin receptor expressing tumor in the liver. But when we did the SPECT CT, we found that this focus corresponds to the gallbladder, and gallbladder happens to be a site of physiologic uptake of this radiopharmaceutical. So remember, indium 111 octreotide can go to the gallbladder. It can look like a tumor in the liver, and this situation can be clarified by doing a SPECT CT. Case number 4 shows a patient who presented with a history of a paraganglioma. Paragangliomas are extraadrenal pheochromocytomas. These are also of neuroendocrine origin, and they can be evaluated by using indium 111 octreotide. The whole body images in anterior and posterior projection shows an anteriorly located focus in the right paramedian mid-abdomen. There is faint uptake in these anterior abdominal wall, and this is at the site of the prior surgical resection of a paraganglioma, and focal uptake here suggests that there is recurrence of the paraganglioma. Here is a patient with history of carcinoid tumor which has metastasized to the liver. In the anterior and posterior whole body images, we see multiple intense foci of uptake throughout both lobes of the liver, consistent with bilobar hepatic metastases. Site of injection is seen here in the left antecubital fossa. Incidentally seen finding is a horseshoe-shaped kidney. Case number 6 shows metastatic carcinoid to the lungs. The whole body images show this faint focus of uptake in the left lung. So remember, findings can be very subtle on a whole body scan, and depending on the findings on other imaging modalities, you may want to do a SPECT or a SPECT CT to further localize the focus of abnormal uptake. So here on SPECT transaxial image, there is intense uptake in the left lung nodule, seen here also on the coronal image, and the bottom right image is a spot view which was taken after cleaning the patient and getting rid of all this other activity that is seen in the region of the perineum. So metastatic disease to the lungs. Another interesting case, this patient presented with history of being hem-occult positive. That led to a colonoscopy which found a polyp in the sigmoid colon, which was biopsied, and a neuroendocrine tumor was found, and the patient was referred for an octreotide scan. On the anterior image, we see this large focus of uptake in the liver. On the posterior image, we see the same focus in the liver, and we see multiple foci in the pelvis. The colonoscopy found the focus was not in the sigmoid colon but in the rectum, and here is that focus localized in the rectum as a focus of increased uptake. There is evidence of bone metastases, there is evidence of presacral nodal metastases, and as we saw earlier, there is liver metastases. So this is a patient with history of rectal carcinoid with bone, liver, and soft tissue metastases. Another interesting case, number 8. The whole body images show a focus of increased uptake in the region of the left ear, the left side of the face, more specifically on this planar image in the anterior and also in the posterior projections. The rest of the whole body shows physiologic distribution in the spleen, liver, excretion from the kidneys into the bladder, and some faint bowel uptake. On the SPECT, there was increased uptake in the middle ear, seen here on the transaxial, sagittal, and the coronal images. And this corresponded to the tumor seen on the patient's MRI that was consistent with a glomus tympanicum, the middle ear neuroendocrine tumor. Case number 9. This is a rare example of a diffuse pancreatic neuroendocrine tumor. You can see here on the anterior image, the entire pancreas is enlarged and shows diffuse increased uptake of indium-111 octreotide. On the posterior image, there is a tenuation artifact from the spine, and that is why the activity is not seen in this region in the midline, but we see that the rest of the pancreas that is visualized posteriorly is swollen and shows intense uptake from a rare diffuse pancreatic neuroendocrine tumor. So those are some of the common patterns that you may encounter when you are reading the indium-111 octreotide studies. Newer PET agents are available to evaluate neuroendocrine tumors, such as gallium-68 labeled dotatate, and with those agents we do a PET CT scan, as gallium-68 is a positron emitters, and they are much better as compared to evaluating those patients with indium-111 octreotide. Thanks for watching.